Welcome back. This is KAK in the morning, and our focus this morning, we are just looking at kidney health right here. And I have an expert as well as a kidney failure patient, that is Stanley Maina, who is just helping us in terms of understanding the journey of a kidney failure patient right here. Stanley, you're just trying to explain to us probably the difficulty in accessing dialysis. That is probably for someone who doesn't understand. How exactly does the sessions go about?
So a typical dialysis session will start when a patient arrives at the hospital, and there will be a nephrology nurse like Ruben Chege here, and so the nurse will connect the patient to the machine via an access, either an AV fistula or a graft or a catheter, permanent catheter or a temporary catheter. Will be the access to access the blood from the body and into the machine, so that the machine can clean the blood and take it back to the body when it's clean. So this process will be repeated for the 4 hours until maybe your UF is done. Your UF is the amount of maybe fluid you've accumulated over the time that you've been at home, or the time that you have not been accessing the dialysis. Yes.
Okay. So Ruben, basically now dialysis plays the roles of the kidney or the functions of the kidney.
Yes. You know, now when it comes to management of the kidney patient, we have 3 things we can do. We call them renal replacement therapy, and dialysis is one of them. You begin with the conservative management, whereby the patient is under follow-up medications just before they get to that point. Or even those who could decline dialysis, they could just be managed, what we say, conservatively, because that's the path maybe they have chosen. They wouldn't want to go through the process of dialysis. And then we have the dialysis treatment itself, and dialysis comes in 2 forms. There is what we call hemodialysis, what Stanley is describing, and we have another form of dialysis we call peritoneal dialysis. So after counseling and after the patient has been diagnosed to be at end-stage renal disease, and now the doctor has prescribed dialysis, the patient will be taken through the 2 forms of dialysis, and then they can choose one form, either hemodialysis or peritoneal dialysis. And then later on, and what we had mentioned earlier, the other form of treatment will be kidney transplantation. The other form of therapy or replacement therapy will now be kidney transplantation, which we said can be done preemptive, even before you begin your hemodialysis sessions, or now once you're still going through dialysis treatment, you now be prepared for kidney transplantation. So those are the 3 forms of replacement therapy that the patient with kidney failure will require. Now, coming to dialysis, we have now the hemodialysis, what Stanley is going through. It's common. It's what now, like, it's readily available countrywide now. We have hemodialysis centers in every county referral hospital. And with hemodialysis, the patient will have the tests done to ascertain the required dialysis. The creatinine will be very high. The urea is likely to be very high. The potassium is also likely to be very, is also elevated. The patient could also be in fluid overload. They have retained a lot of fluids, and that now indicates that they require dialysis. Then we have the center where you will need to have the trained personnel. You have your nephrology doctor, and you will have your nephrology nurses. You will require the dialysis machine itself. The machine also, in that center, we will require water. Water is very key. Without availability of water, you can't do hemodialysis. So, and that water has also to be treated. So we will require a water treatment plant to set up a dialysis unit. So once you have those in place plus the other equipment, the patient comes and they will have a creation of the means by which we shall be drawing blood from the patient. What Stanley is referring to as the access. He has called it temporary catheter, we call it acute catheter, chronic catheter or permanent catheter, which is inserted through the vein, a main vein, to the right atrium of the heart, just at the tip of the heart, so that we're able to draw blood with the help of this dialysis machine to circulate that blood through the machine. The blood doesn't get inside the dialysis machine. It circulates outside because we have tubings. We have the catheter, or we have what he was calling AVF, arteriovenous fistula, is a vessel. Two vessels that have been joined together, an artery and a vein. The vein will become bigger, have the characteristics of an artery, and that's why we shall be pricking, we shall be inserting our needles to draw blood from the patient. So once we have that, then comes the process of dialysis. We will have blood tubings, which will be drawing now blood from that access to circulate to the machine. And also we have another component we call the dialyzer. It's a hollow fiber thing that will act as the artificial kidney. That is where the dialysis will be taking place. That is where the exchange will be taking place. In that dialyzer, we have two chambers. We have one chamber that contains blood from the patient flowing through the dialyzer. We have another chamber containing what we call dialysate, the treated water I was mentioning, with a combination of another acid concentrate and a bicarbonate, forming now what we would call ideal blood. This ideal blood will have concentration of the electrolytes we were mentioning, the sodium, the calcium, the potassium and others in normal levels or slightly normal. And then we have in the blood, we have a concentration of now the toxins that we want to remove. So what happens in this dialyzer, there will be an exchange. There is a separation of these two chambers using a semi-permeable membrane. If you remember in our biology class, there was what we used to call a semi-permeable membrane. This will now allow diffusion, the movement of these concentrated products, the solutes, to move from the region of high concentration to a region of low concentration. And mainly, you will have high concentration in blood, like potassium, for example, will be high in blood and low in this dialysate. So you will have potassium moving from blood to this dialysate and off to the drain. And that continues for 4 hours. So if he came with a potassium, for example, of 6, by the end of dialysis, it's likely to have gone down to around 3.5. And then, of course, the other products will also pass through the pulse passively. The creatinine, the ureas are removed during dialysis. So the circulation of blood enhanced by a pump in that dialysis. There is a pump that keeps rotating, creating negative pressure, pulling the blood from the patient and creating a positive pressure, pushing the blood back to the patient. And the cycle continues for 4 hours. So a standard dialysis is 4 hours, but you can prolong it depending on the goals of what you want to achieve. During the same session, the patient also, as Stanley was mentioning, could come with fluid overload. So the machine is able to create some positive pressures in that chamber, blood chamber, some negative pressure in the dialysis chamber, and that way we are able to pull excess fluid from the patient. So what we do when the patient comes, we do a physical examination. We are able to assess the patient, look for fluid, signs of fluid retention, the puffiness, the swelling of the lower limbs or the hands, sometimes some breath sounds. You listen to the chest and you can be able to hear some sounds that will tell you this patient is really fluid overloaded. And now you come to the machine, you do some settings of how much fluid you would want to remove, what we call ultrafiltration from this patient. So in the period of 4 hours, you could remove up to 4 liters or 4 kg from this patient. And you will have weighed the patient before dialysis and you weigh the patient after dialysis to see whether you were able to achieve this goal. So that's how a dialysis session goes about, with the help of the dialysis machine, treated water there, and then the pump that is rotating. This blood during dialysis, you see it's outside the body. We call it extracorporeal circulation. It's likely to clot because it's outside the body, the temperature outside the body, the tubing, sometimes the pump can stop. So during dialysis, sometimes we give them some medication continuously to prevent that blood from clotting, because they could lose that blood, which is unfortunate. And you know, with the kidney problem, we said one of the other problems they have is blood formation. So you don't want to lose this blood during dialysis. So this continues. The WHO recommends 12 hours a week.
Okay.
That is now the 3 sessions a week.
Okay.
Each 12 hours. But our setup here, because of scarcity of resources and affordability, we normally offer 2 sessions in a week, minimum.
Okay.
Yes, and as he has mentioned, we have the privilege of the NHIF paying for them 9,500 per session, and which is a very, very good thing that has happened to our clients. Now that has helped to improve their quality of life and also prolong their life, because as he mentioned, when they used to pay out of pocket, many of them could not afford, and therefore many fell along the way. But at least with the NHIF covering 9,500 every session, at least it lightens the burden for our kidney patient. Yes.
Okay, now Stanley, from Ruben's explanation, I mean 4 hours, just seated for 4 hours, it's quite not a joke. I mean, sure. What do you do like during the 4 hours? What exactly happened? How does your body, how does it usually feel like?
Okay, in the 4 hours of the dialysis session, most patients would prefer to just sleep through the sessions. But you can also do sorts of things like maybe watch a video, listen to some music, talk to someone. Those are basically because you have some restriction of movement. And usually when you're on dialysis, before you go into the machine, when you're from home, you're usually tired because your body is full of toxins, maybe full of fluids, and you're struggling to breathe. So you usually feel it's the worst. It's the worst thing you can ever experience. But after the dialysis session, you feel like a new person. Your body is lighter. Maybe you've removed 4 kgs. You can feel like you're just a new person, and you can say that you can look forward to another dialysis session.
So is it tedious, painful?
No, there's no pain involved unless you have the ultravenous fistula. Then you'll have to get the prick, and that's just a little pinch of pain. But for me, I have a permanent catheter, so there is no pain. The catheter is just there permanently. Just open the access, and they connect the other pipe to the other pipe, so there is no pain. The only thing I can say is you can just get really tired after a dialysis session, especially if you're getting a lot of fluid. You have a lot of fluid, say 4 liters, and you go, there's the blood pump, the pump that you said that pumps the blood out of the body. When you're going at high speeds and you have a lot of fluid, when you get out of there, it will be like utasikia ni kama umetoka shamba, utataka tu uende ulale tu pahali for at least 8 hours, alafu ndo utafeel uko sawa. So that is just a typical dialysis session for me. Yeah.
All right. And now, Ruben, you mentioned still the dialysis. And do you take medications like after the dialysis, or is it just the dialysis?
Okay, for me, I don't take any medications. I just do the dialysis because the only other condition that I had is there are medications that we take regularly, every other week or every other month, depending on how your results came in. So there are medications for bones because your bones get weak. You saw me coming with the clutches. My bones became weak, and I had fractures on my hip joint. I had to be put screws. So there are medication for bones, vitamin D, calcium, and vitamin D, calcium, and calcium. And there are medications for blood, as he said, erythropoietin, and the other one is
iron sucrose.
Iron sucrose. Yeah, you have to get them every other week. Otherwise, your blood levels will go down, and you'll have to do a transfusion, which is not usually recommended.
Okay.
The other medications you may be taking are now the hypertension and diabetes if you have either of those. So for me, I usually take the bone medication and the blood medication.
Okay.
Because I don't have hypertension or diabetes.
All right.
Yeah.
Okay. Now, on just that note, just taking these other medications, or even the dialysis, as you put it, the blood clots, probably in case that would happen. What are the chances of these other medications? Because you talked of drugs affecting someone's kidney. What are the chances of this person with a kidney failure, of them probably, of the drugs that they are taking, the dialysis, affecting other organs in their bodies?
Well, the drugs they take are for management of the conditions they have.
Okay.
If they have diabetes, they have to continue maybe with their oral drugs. A number of them, once they are diagnosed with kidney disease, some may continue with their insulin, some may have to stop for a while. Huh? But now these other drugs they are taking are also to help manage some of the complications that arise as a result of having kidney problem. Because once they suffer from kidney disease, they have mineral bone disease. That's why their bones become weak. And that's why they have to keep getting calcium and vitamin D, just trying to strengthen their weak bones. Okay. Then they have to get the antihypertensive drugs because, as we said, with kidney disease, there is a likelihood of even your BP also going up. Then they have to also get what he has said as erythropoietin to keep, it's a hormone replacement. Because their kidneys are no longer forming the erythropoietin, you give it via injection to try and boost their blood formation. So we are looking at the other organs are affected by the treatment process, not necessarily by the dialysis, but not necessarily by the drugs they are likely to take. Those drugs, the phosphate binders, they are just trying to manage some of the problems they are likely to experience as a result of having kidney disease. Yes.
All right. And now to you, Stanley, you just mentioned of even if NHIF is probably providing the 2 sessions a week, what would you say, probably just to the policymakers, the government, what would you say is the greatest challenge of a kidney failure patient and what can be done?
Okay, the greatest challenge, as I've said, is accessing, being able to afford this whole, say, experience. Because, as I said, when you're on dialysis, you're told it's a lifelong thing. And when you start, you have a lot of friends, you have a lot of family members who can support you. And this becomes a burden as time moves on. And the only other way you can help this kind of person is by maybe a transplant. That is the only thing that can get you out of this condition. Now, what the government could do to help kidney failure patients is by allowing the NHIF to cover for some of the drugs that patients are usually required to take after transplantation. Because you might find someone who did a transplant, amefanya transplant 6 months, amemanage kulipa hizo drugs, kununua hizo drugs, and they're usually very expensive. Dr. Ruben can tell you the prices. They're usually very expensive, but not as expensive as dialysis. So it usually gets unashindwa, why couldn't they just pay for these drugs rather than dialysis? So what I would ask the government is to consider creating new policies to allow the NHIF to pay for these post-transplant drugs because they are even cheaper than dialysis. And a lot of people have donors, they just don't have the money to do the transplant and manage the transplantation after getting the transplant. They are not able to buy the drugs. The other thing could be, in Kenya, getting a transplant is very easy if you have relatives who are willing to give you the kidney. But most of the time, like in my case, most of my relatives, we don't match blood groups, and after doing some number of tests, Also, we find that we can't do the transplant because maybe they have other underlying conditions that we didn't know of. So if the government could also allow non-related transplants, where you can just have someone who's willing to donate to someone and they can just go and have their transplant, that could be a very great thing. It could lessen the burden to a lot of people, because when you're on dialysis, it's very hard to go to work. Even someone will be wondering, how will they employ you and you
keep on going like
every other
3 times a
three
week.
times a week. You're off work for 4 to 5 hours. And also when you're after dialysis, it's hard to work because you're really tired. So that is what I would ask the government to do.
Okay.
To allow non-related transplantations, and also to work on a policy where transplanted patients can get drugs with their NHIF cards from hospitals, so that they reduce the number of rejected kidneys. Because a lot of patients on dialysis already had transplant, even twice. But due to maybe they didn't have the funds to buy the drugs, the kidneys rejected them and they had to go back to dialysis. So it becomes a very huge burden on them. Yes.
Right. That's very great, and we hope that the policymakers will work on that.
Yeah.
Now, Stanley has just mentioned something probably that I'd want you to shed some light on. As Ida, like I can't just get out of somewhere and come and say I want to donate my kidney to Stanley.
Well, you can't. And maybe it's also good to mention in this show that you cannot sell your kidney.
Okay.
Because we receive a lot of calls. We have people visiting the hospital and they come saying, I want to sell my kidney, out of maybe poverty there, and they think like if they sell their kidney, that it's going to be to help. In our country, the regulations do not allow. There is no commercial aspect when it comes to kidney donation. That is number one. Number two, our policy currently, or our laws currently, they allow life-related donors.
Okay.
You have to be related with the client for you to be able to donate. And during counseling and during preparation, we will be able to find out. We'll be able to ask questions to find out how are you cousins, how are you related with these.
Okay.
So we normally talk of life-related donors. That is where we are currently. Maybe in future, as we say, we have a health bill that is being worked on that maybe could allow in future swapping of maybe donors, where you have a donor whom you're not matching, he has a donor whom you can match, and then we can allow your donor to donate to him and his donor to donate to you. We are looking at those proposals. Then we have another aspect we are looking at, we call deceased donor transplantation, whereby we can be able to harvest the organs that are transplantable from a brain dead patient. But this one will require you will have to have given consent, like in other countries, advanced countries, you normally give your consent before death, that in the event that I suffer maybe from a crash, accident, and there are no chances of survival, you can harvest my kidneys, you can harvest my cornea, you can harvest my heart, those kind of things. We haven't gotten there yet, but the bill and the laws are in Parliament, they are being worked on. Once they are given consent, then, and I think they are in very advanced stages, then regulations will be put in place, how we can go about that. But as of now, we are only taking life-related donors, and there is no selling or buying of kidneys in our setting. Yes. However, we would want to encourage people to if you are related to a kidney patient, kidney transplantation and donation is doable, it's possible. And on the side of the donor, usually there's a lot of also investigations that are done to ensure that once you donate your kidney, you are also not left in danger of suffering from kidney disease. We only take donors who are very, very healthy. We do not risk the life of donors, and that's why you can come with a donor along the process. The donor is dropped because we detect they have one problem, they have BPs, they have protein in their urine, they have, okay, some things that cannot be managed, or they can be managed, but if you harvest a kidney from them, you are leaving them at risk.
Okay.
But in a normal situation, kidney donation is possible, and after donation, your life continues. And actually, you can survive very well with one kidney. One functioning kidney can take you well. You will still have your family, you will still conceive if you are ready, you will still be able to give birth. If you are a man, you will still be able to have your family, you will still be able to go back to your work. So it does not affect your life because you donated a kidney.
Okay.
Yes. And then maybe to add on what he has said, when it comes to NHIF, very good. We are now having them supported on dialysis. We are looking forward that in future, as he has mentioned, that it's still paying for kidney transplant. During the process of kidney transplantation, there is a certain amount of money NHIF will pay for surgery. But now what he's saying, which is very important, is the maintenance of the transplanted graft, the donated kidney. Because it's a foreign thing, it doesn't belong to you. Your body produces some antibodies that could fight that transplanted kidney. So that's why they will require some medications, we call them immunosuppressants, to help prevent the body from rejecting the donated kidney. And those medications, as he has mentioned, are quite expensive. You will be spending up to 40,000 every month. And that becomes a challenge to a number of our patients. So maybe if that can be looked into, they will have really gained on that. Because now transplantation is one thing, maintaining the kidney is another thing. And that's what is also very, very important. And that's transplantation is the only way to get off dialysis. Yes.
All right. Okay. Now, to you, let us just very briefly, Stanley, how do you live your life currently, just in terms of managing the condition that you have and also preventing any other condition from affecting you?
Okay. Currently, the only way I'm managing to stay at top of everything is by making sure I don't miss any dialysis session. I usually try very hard everywhere, every means that I can get to the hospital and manage the dialysis. Because the moment you start missing dialysis sessions, that's when other problems start coming in. Like you may start having heart problems because your fluid levels are too high and your heart is fighting very hard to make sure it balances the fluids in your body.
Okay.
So dialysis is the first thing that I usually make sure I don't miss any session. The second thing is making sure my blood levels are always at a good manageable point where I don't have to go to hospital and get a transfusion.
Okay.
I usually make sure that it's around 10 to 11 to 12 points. And the other thing is the medications, the bone medications. Though there was a time where I didn't have enough money to get the medication, like the vitamin D activated. That's when I had an accident and I broke my femur. Mostly other conditions we usually get vaccines, like for hepatitis, all the hepatitis and hepatitis, I guess. That is the vaccine that I got for. COVID, we had to get the vaccine also as soon as possible because we were very vulnerable to that condition. And I guess we also try very much to maintain a very good diet that doesn't put a lot of toxins in my body. So my diet is very restricted. The amount of water I can take in a day is very restricted. The types of food that I can eat also very restricted, so that I make sure I don't get to hospital to a point where it's an emergency. I have to do this. It is just a manageable thing if you follow your diets and do all these other drug-related programs to make sure you don't find yourself in an emergency in hospital.
Okay.
Yes.
All right. To you now, Ruben, in terms of managing, you've not been diagnosed with kidney failure or kidney disease. How do you manage? Because we are looking at kidney health for all, both those that have been diagnosed and these people that have not been diagnosed. How do you take care of your kidney?
We would start by saying that, one, kidney disease is preventable. It is preventable, and we can be able to do primary prevention program so that we don't get there. And one of the things we need to look at is our lifestyle, because we've seen hypertension and diabetes are major causes of kidney disease, and those are mainly lifestyle diseases. Though there is usually the aspect of family history, but if you are able to do exercises, if you're able to avoid obesity, if you're able to have your checkup, if you're able to avoid those self-medication. Some people do self-medication with some of herbal. I'm not saying herbal complementary medicine has an issue, but some of those ones are harmful without proper guidance. So if we look at prevention, there are things that we do. There is now the issue of checkup. You do not have the disease, but you want to prevent. What about men going for prostate evaluation, especially after the age of 40? Because if by the time you're going there, you're having obstruction, damaging your kidney. So to avoid getting there because of obstruction, you go to the clinic, wellness clinic, have your prostate checked. Yeah. What about expectant mothers going for antenatal clinic and they are diagnosed early for issues of what we call eclampsia or preeclampsia, high BP during pregnancy? Yeah. And then those kind of things are basic, but they can prevent kidney disease. What about children who suffer from sore throats and they have to go and get treated to avoid them getting those kidney infections that could arise from such? What about avoiding some other issues that are hygiene related, like diarrheal diseases, dehydration, drinking of water? Because we have another form. We have majorly dealt with the chronic kidney disease, but we have another form of kidney disease. We call it acute kidney injury, because it occurs because of lack of either enough volume in the body, and that can occur because of burns, severe burns, accidents where you lose a lot of blood, dehydration because of diarrheal diseases. So if you avoid such, you avoid acute kidney injury. And this acute kidney injury, if not well maintained, can lead to chronic kidney disease. So you prevent the occurrence of such things. So kidney disease is preventable to those who do not already have it, and to those who already have it or who are in stage 1, you can reduce the progression. The rate at which you are deteriorating or you are losing your kidney function, because all of us will start at 100%, but even also as we age, we keep losing a certain percentage. But you can now hasten this by what you are eating and what you're doing. So if you can be able to manage that, then you are preventing the progression. Compliance to medication. We have people who have hypertension, but they take drugs when they feel like, or when they feel like they are having a problem. They are not following the treatment regimen by their doctors. We have people with diabetes, they are taking medications on and off, they are not following. That puts them at risk of progressing to end-stage renal disease very, very, very fast. Patients with heart diseases will require good follow-up at the clinic level. And then also health education now to our masses. That's why we have the World Kidney Day. We are talking about kidney health for all, to create this awareness such that if you have this kind of symptoms like Stanley was saying, you don't stay at home. You also visit a dispensary. If you have not been sorted, you don't go back there. You go to a higher level to have yourself properly screened. And then we have now, like during the World Kidney Day, we are doing this education and we are doing screening. Very basic things like having a urine test to check whether you have protein in your urine or blood in your urine, which can be an early indicator of kidney function problem. Then you get treated early enough. issues of checking your blood sugar. That's what we'll be doing. And even simple thing, having your BP checked.
Okay.
We said it's a silent killer, hypertension. Come, have it checked.
Yeah.
Or many have come and they are like, what? I didn't know. Yeah, so it's good to have that wellness checkup.
All right.
Yes.
Okay, Stanley, anything you'd want to add as we wind up?
Yes, I want I'd like people to support the World Kidney Day, which is on 9th March. The theme of this year is supporting the vulnerable and creating awareness so that you can have preventive measures like Dr. has said. Also, I'd like to give to nitakupea watu wenye wako kwa dialysis motisha kabisa juu najua Kenya mnapitia na ni ngumu sana, na I would just like to give them a word of encouragement that you don't have to wait for things to get better so that you can be happy. Just do what you can do, manage your condition, and your life can be normal again. Yeah, also, yeah, that's it.
You okay?
Yeah, I'm okay.
All right. For you, very briefly.
Well, kidney disease is preventable. Let us do our part as a society and in ensuring that we do not engage in a risky lifestyle that would put us at risk of this kidney disease and even other diseases that are lifestyle related, because kidney disease is just one of the diseases that would arise from that. And let's support our patients, our clients who are having kidney disease. Let's have social support. As Stanley was saying, friends disappear, family disappear. No, kidney disease is not a death sentence. They still live. Let's support them the best way we can. And to the health providers who are working with the kidney patients, good work, continue, do not tire, and shall be well. Yes.
All right. Thank you so much, Stanley Maina and Ruben Chege, who is a renal nurse or a nephrology nurse. I said it right?
Yes, nephrology nursing.
All right. Thank you so much for your time,
Yes.
and thank you for shedding light. I'm sure our audience now have a better understanding of our kidney health.
Yes.
All right. So we will be taking another very short break. When we come back, we'll just be looking at news at this hour.